To manage this massive amount of clinical data without getting overwhelmed, we are using a strict roadmap. We'll hit classification and symptoms, diagnosis and treatment methods, brain metastases, glial tumors, meningiomas, and childhood tumors, and finally, we'll wrap up with the pituitary, lymphoma, and the spine. Okay, let's dive into this. This single clinical pearl perfectly establishes the extremely high stakes of neuro-oncology. Imagine an adult who has absolutely no history of epilepsy, and they suddenly drop into status epilepticus. In the ER, your first thought shouldn't just be about stopping the seizure, it absolutely must be about ruling out a mass. This simple rule dictates that we have to investigate deeper, because that sudden electrical storm in the brain, it's often the very first alarm bell of a rapidly growing tumor. So, Section 1, Classification and Core Symptoms. A brain tumor's presentation is essentially just a map of its location, right? Like if there is a lesion in the frontal lobe, you're going to see profound personality changes. A truly fascinating, though tragic, clinical phenomenon here is Witzel syndrome, which actually presents as pathological, uncontrollable joking right alongside antisocial behavior. Now, if the tumor sits in the temporal lobe, the patient might present with straight-up psychosis. Occipital lobe, you're looking at visual disturbances. But remember, regardless of the lobe it's in, any expanding mass is eventually going to cause raised intracranial tension, or ICT, and this universally presents as nausea, vomiting, and a headache that is notoriously classically worse in the morning. Moving right along to Section 2, Diagnosis and Treatment Methods. Now, what's really interesting about this is the stark contrast in our radiotherapy arsenals. On one hand, whole-brain radiotherapy is a really broad approach that, unfortunately, causes high collateral damage and significant brain swelling. But on the other hand, stereotactic radiosurgery, like the Gamma Knife, is totally a sniper approach. Multiple precisely guided rays converge on a single target, delivering maximum destructive energy directly to the tumor with minimal collateral damage. It's a real game changer, heavily utilized for metastases, AV malformations, and trigeminal neuralgia. And to even plan these high-tech treatments, we rely on the absolute gold standard of diagnosis, the gadolinium-enhanced MRI, because it gives us that detailed tissue contrast a standard CT scan just can't match. Section 3, Brain Metastasis. And spoiler alert, this is the most common one. Look, if you take away absolutely nothing else today, remember this golden rule. Metastasis is the most common brain tumor overall, period. Lung cancer is the #1 offender for metastasizing directly into the brain parenchyma, specifically setting up shop at the gray-white matter junction. Breast cancer, on the flip side, tends to favor spreading to the leptomeninges. Now pay super close attention to the diagnostic rule here. You must use an MRI. Do not fall into the trap of relying on a PET scan. A PET scan is notoriously terrible for diagnosing brain mets. Why? Because the brain naturally takes up so much glucose that it literally masks the tumors. For treatment, if it's a solitary lesion and the primary cancer is under control, surgical removal is totally possible. Otherwise, we rely on that sniper approach, stereotactic radiosurgery. And importantly, steroids are the absolute drug of choice to control the incredibly dangerous vasogenic edema surrounding these lesions. All right, Section 4, Glial tumors, covering everything from astrocytomas to ependymomas. So, the crucial point is how astrocytomas exist on this really deadly spectrum. At grade 1, we have the pilocytic astrocytoma. This is the most common one in kids, usually found in the infratentorial posterior fossa as a benign mural nodule that surgeons can actually just excise. Grade 2 is the low-grade fibrillary. It's a slow grower, sure, but it has this lurking danger. A P16 or CDK mutation can suddenly trigger it to progress. Grade 3 is the anaplastic astrocytoma. This one shows up as an irregular, enhancing lesion demanding aggressive surgery and whole-brain radiotherapy. And then we hit grade 4. Grade 4 is glioblastoma multiforme, or GBM. It's famously and tragically known as the butterfly tumor. Why? Because of its aggressive ability to actually cross the midline of the brain, creating this chilling butterfly shape on an MRI. Pathologically, it's defined by these hallmark signs of endothelial proliferation and deep tissue necrosis. The progression here is brutally rapid. We're often talking a matter of months. However, the introduction of an oral chemotherapy called temozolomide has slightly revolutionized care, adding some highly precious months to overall survival times. Continuing our fast-paced run through glial tumors, let's hit some classic pathology buzzwords you absolutely need to know. Oligodendrogliomas are genetically linked to a chromosome 19q mutation. Under the microscope, they have a super distinct fried egg cell appearance and what's called a chicken wire vascularity. On an MRI, you're going to spot intratumoral calcifications. Then we have the ependymoma. These arise from the ependymal cells lining the brain's ventricles, mostly striking the fourth ventricle in kids, which blocks fluid and causes hydrocephalus. Because they literally sit in the fluid pathways, they uniquely spread via the cerebrospinal fluid, a scary phenomenon known as drop Mets. To fight this, treatment usually requires full cranial spinal irradiation, and, pathologically, you'll see pseudo-rosettes. Lock those buzzwords in for sure. Next up, Section 5, meningiomas and childhood tumors. And this brilliantly illustrates how extraaxial lesions behave uniquely. Meningiomas arise from the meningioepithelial cells of the arachnoid. They are slow-growing, encapsulated, and importantly, non-infiltrative. On an MRI, because they sort of pull on the dura without actually invading the brain tissue itself, they present with the incredibly famous dural tail sign. Pathologically, they're loaded with these distinct calcifications called Samoma bodies. When surgeons go in to remove them, they evaluate their success and the risk of recurrence using the highly specific Simpson grading scale. Turning our attention to pediatrics, the medulloblastoma is the most common malignant primary brain tumor in children. Like a lot of pediatric tumors, it's infratentorial, specifically parked in the cerebellum, meaning it causes severe ataxia and raised intracranial tension. Like ependymomas, it features those scary CSF drop Mets. But uniquely, and this is wild, it can actually metastasize completely outside the central nervous system to the bone and the liver. But there is a silver lining. It is incredibly radiosensitive. Also, genetically, you should always associate it with Turcotte syndrome, which is a variant of familial adenomyosis polyposis. All right, the final sprint, Section 6, pituitary, lymphoma, and spines. Let this number really sink in for a second. 90. 90% of patients dealing with a craniopharyngioma end up suffering from hypopituitarism. Why is that? Because this benign tumor, derived from Rathke's pouch, grows right next to the pituitary stalk and compresses it severely. And since it often strikes children, this profound hormonal suppression leads to growth retardation in about 50% of cases. So managing the endocrinology is quite literally just as vital as the neurosurgery itself. Looking at some highly specialized lesions, the acoustic neuroma parks itself right at the cerebellopontine angle. It compresses cranial nerves, primarily causing unilateral sensory neural hearing loss and tinnitus. Next, the pituitary adenoma. The most common functional type here is the prolactinoma, which causes amenorrhea and galactorrhea. Because it sits right at the optic chiasm, large adenomas will cause bitemporal heminopia. Basically, you lose your outer peripheral vision. Interestingly, prolactinomas are uniquely treated first with medical therapy, specifically bromocriptine, just to shrink them down. If surgery is ultimately required, the preferred route isn't actually opening the skull. It's the transsphenoidal approach. They go right up through the nose and sphenoid bone. Incredible, right? Okay, here is an absolutely vital clinical pearl, a primary CNS lymphoma, specifically a diffuse large B-cell lymphoma, which we see increasingly in immunocompromised patients, is known in the field as a ghost cell tumor. Why? Because if you give the patient steroids to reduce their brain swelling, the cytolytic effect of those steroids will cause the tumor to rapidly regress and literally vanish from the scans. You must stop steroids before performing a stereotactic biopsy, or the tumor will just disappear and you'll be left with a completely ruined non-diagnostic sample. To round out our foundational knowledge, we have 3 rapid-fire, absolute high-yield rules regarding the spine. First, the most common spinal tumor overall, well, just like the brain, it's metastasis. Second, the most common primary spinal tumor, that would be nerve sheath tumors. And third, the most common tumor growing physically inside the spinal cord tissue itself, the intramedullary tumor, that is the astrocytoma. Lock those 3 one-liners in, they are gold. Let's move to and see how this builds toward the future of medicine. We've just mapped out the strict diagnostic and surgical blueprints of neuro-oncology as they stand today. But, with discoveries like the 19q mutation in oligodendrogliomas and the p16 mutation in astrocytomas, the entire horizon is shifting. As molecular and genetic therapies rapidly evolve, how soon will targeted interventions rewrite or perhaps entirely obsolete these surgical rules we've just spent time learning? It's a fascinating question, and it's exactly what keeps the field of neuro-oncology on the absolute cutting edge. Thanks for focusing in with me today on this explainer. Keep asking questions and definitely keep exploring.